Bismillahirrahmanirrahim. So today we are going to study about the another antidepressant subgroups, and this is known as monoamine oxidase inhibitors. So, but before studying the monoamine oxidase inhibitor, we must know what is monoamine oxidase. So, monoamine oxidase, it is a mitochondrial enzyme, and it is mostly present in the areas like neuron, the gut, and the liver. And what is the role of this monoamine oxidase in the neuron? That in the neuron it usually inactivates the axis neurotransmitter molecules like norepinephrine, dopamine, and serotonin, and this axis neurotransmitter may leak into a synaptic cleft when the neuron is at rest, and it can result in unwanted effects. So in order to prevent these unwanted effects, the monoamine oxidase do what? They degrade and metabolize these neurotransmitter. Now the monoamine oxidase has two types, the A and B. The A type is mostly present in the areas like the gut, liver, etc. And the B type is mostly present in the brain. The A type mostly metabolized neurotransmitter like the norepinephrine, epinephrine, and the serotonin, and the B type mostly metabolized the neurotransmitter like the dopamine. So these were some differences between the monoamine oxidase A and B, and some points regarding the monoamine oxidase. Now let's jump into the monoamine oxidase inhibitors. So the monoamine oxidase inhibitors are divided. The drugs are divided into two groups: a selective one and the non-selective one. The non-selective one and the selective one. And in turn, this selective one are divided into two subgroups: the monoamine oxidase A inhibitors and the monoamine oxidase B inhibitors. So now let's study the drugs which are included in these groups. So the non-selective one includes drugs like the isocarboxylate and the penicillin, and the selective one includes the drugs like those which inhibit the monoamine oxidase A inhibitors, include the drugs like the moclobemide, and those which degrade the B monoamine oxidase inhibitors, they include the drugs like the silicyline and rasagiline. So isocarboxylate, penicillin, moclobemide, silicyline, and rasagiline. The important point regarding the silicyline that it is the first antidepressant available in the transdermal delivery system. Transdermal means that it can be put under the dermis in the skin, and from where it can be absorbed slowly and show its antidepressant effect. Now let's study about the mechanism of action of the monoamine oxidase inhibitor. So in order to learn the mechanism of action, let's jump into the blank screen. So for example, we have two neurons ending. We have two neuron endings. It is the presynaptic neuron ending, and it is postsynaptic. The presynaptic neuron ending contains vesicles. These are vesicles containing the neurotransmitter, and the postsynaptic have receptors for these neurotransmitter to act upon, and this is the synaptic cleft. Now when the neurons receive the signal, i.e. when it is activated, these neurotransmitters present in the vesicles are released into this synaptic cleft like the norepinephrine, epinephrine, dopamine, serotonin, etc. And these neurotransmitters acts on these receptor, and thus there is postsynaptic response. But when the neuron is at rest, there is no release of these neurotransmitters into this postsynaptic cleft. But when there is excess production of these neurotransmitters, they are get released into the neuron, and from here it gets directly into the synaptic cleft without any activation. In synaptic cleft, it activates these receptors, and thus there is unwanted effects. So in order to prevent these unwanted effects, what is the mechanism in the neurons? We have monoamine oxidase enzymes in the mitochondria. This is the mitochondria, and we have monoamine oxidase enzyme. These excess neurotransmitters which are released from the vesicles when the neuron is at rest, they are metabolized by the monoamine oxidase in the mitochondria, and thus they are not released into the synaptic cleft. So now what this monoamine oxidase do? Monoamine oxidase inhibitors do, they inactivate this monoamine oxidase, and thus the excess neurotransmitters which are released from the vesicles are not metabolized by the enzymes in the mitochondria by the monoamine oxidase enzyme, and thus they are redirected to the synaptic cleft. As in depression, there is already decrease in the neurotransmitters like dopamine, norepinephrine, as we have already discussed the monoamine theory of the depression, serotonin, etc. So increase in their concentration will relieve the depression. So this is the mechanism of action by which the monoamine oxidase inhibitors do. Now let's study it in the diagram. So this is the normal monoamine transmission. This is the first presynaptic neuron, and this is the postsynaptic neuron. This is vesicles, this is mitochondria containing monoamine oxidase. In normal neurotransmitters, these excess neurotransmitters are degraded by the monoamine oxidase present in the mitochondria, and they are not redirected to synaptic clefts, and there is no unwanted effects. But in depression, there is decrease in the concentration of these neurotransmitters, so we have to block this monoamine oxidase in the mitochondria, and by blocking this, these neurotransmitters are directly directed towards the synaptic cleft, and thus there is increase in the concentration of these neurotransmitters, and they act on these postsynaptic receptors to produce the postsynaptic response. We have already discussed about this. Now what are the indications of the monoamine oxidase? So they are used in the depressed patients who are allergic to the tricyclic antidepressants, or who along with depression experience strong anxiety. So depressed patients who are allergic to the TCAs and who experience strong anxiety. They can also be used in the atypical antidepressants, and they can also be used in the phobic patients. Now what is the main disadvantage of these monoamine oxidase inhibitor? That we use it as a last line agent for depression, and it is mainly due to two reasons. The first one is the drug food interaction, and the second one is the drug drug interaction. So what is drug food interaction? Normally we have tyramine. It is a catecholamine releasing agent. So it releases the catecholamines from the presynaptic neurons, and this catecholamine in turn acts on the postsynaptic receptors and causes effects like the hypertension, tachycardia, etc. So normally this tyramine is present in the aged cheese, meats, pickled, smoked fishes, and red wines, and this tyramine is normally inactivated by the monoamine oxidase in the gut, present in the gut. But when we inhibits this monoamine oxidase by giving the monoamine oxidase inhibitor, they are unable to degrade this tyramine obtained from these kind of diets. So in turn there is increase in the tyramine, and which is when it is absorbed from the gut, it causes the release of large amount of stored catecholamines from the nerve terminals, and it can result in the hypertensive crisis, which is characterized by the very high blood pressure, very high hypertension like 180 by 120, headache, there is very confusion state, etc. And these are symptoms of the hypertensive crisis. And the second one is the drug-drug interaction, that we cannot use the monoamine oxidase inhibitors in SSRIs because they can lead to serotonin syndrome, where there is increase in the concentration of serotonin. Because SSRIs, they also increase the concentration of serotonin, and the monoamine oxidase also increase the concentration of serotonin. So if we co-administer these both drugs, then it will increase in the much more increase in concentration of serotonin, and it can lead to serotonin syndrome. So in order to give the monoamine oxidase inhibitor, we have to do washouts of the SSRIs for about 2 weeks or vice versa. So that's all regarding the monoamine oxidase inhibitors. Thank you.